All right. Hello, health heads. Welcome and thank you for checking into this dose of the Healthcare Uprising. I'm your producer, Jeremy Carr, here with your host, Heather Pierce. And so what's on our agenda for today, Heather?
We get to bring back somebody again. Yay. Hey, that's
returning guests.
That's a sign of a successful podcast, Jeremy.
Season 3, you start getting return guests. I didn't even know that until we got there.
Yeah, so that's what we're doing. So we've got Pachet Bryant, CEO and founder of MINE Maternity, coming back to talk with us about all the kind of the new exciting things that's happening in her world around growth and how they've expanded and how they're showing up a little bit differently in the world to have a little bit more impact on women through their maternal health journeys. So
yeah, it's actually, now that I think about it, it's kind of similar to recently when Guava came back on, because they've expanded to like new territories with what they're doing. This is kind of a similar aspect for mine. And
using the provider network, using the providers to show up and establish trust right out the gate.
Yeah. So the great news for the whole pregnancy community, I guess, going on here. So without further ado, let's jump into our next conversation with Pachet Bryant from MINE Maternity.
Hi, and welcome to the Healthcare Uprising podcast. Today we have Pachet Bryant, CEO and founder of MINE Maternity, a return guest, friend of the pod. Welcome back. We're so happy to have you.
Thank you. It's always nice talking to you.
Yeah. Exciting times. We love bringing people back. That's a good sign, right? Jeremy was just saying that.
Yeah, season 3's been a lot of that.
Yeah, a lot of return guests, which is exciting for us and exciting for you because we're still here. And second, because that means that you've got some big stuff going on. So to start us off, tell us about kind of who you are, who's MINE Maternity, what do you do to serve the people, and then we'll get into some of the updates and things that are going on in your world.
I love it. Well, it's good to be back. I always like chatting with you. And welcome, everybody. Nice to be back as well. So for those who are meeting me for the first time, my name is Pachet Bryant, MINE Maternity CEO and founder. MINE Maternity is essentially an insurance navigation support company for maternity providers. So that's, supporting our doulas, our lactation consultants, our midwives, our OBs. Really, if it's within the maternity scope, even if it's like chiropractic care, but they focus on maternity patients, we support them in making sure they can help you. So that's oftentimes how we're met with families, is through your trusted provider who says, they can help you with reimbursement, or we can, support with claims and any billing questions, or even, navigating your insurance benefits or employer, specialty benefits. So that's a little bit about what we do.
Awesome. And you've been around now for how long?
Me as an individual?
Mine. No, you never ask a woman her age.
Especially in public.
That's right. No, MINE Maternity itself, because I think if I recall, you launched it in 2017, but then you went through some transitions. So the kind of, I guess, say like the operating model as it stands today, how long have you been kind of functioning that way?
Yes. So operating model today would be end of 2024, beginning of 2025. We're focusing on the insurance piece. And it's funny because we were a care coordination company prior to that. But we kept getting so many questions about, well, how do I check my insurance benefits? Can you do it for me? Or providers saying, how do I bill? What's coding? What's CPT codes and all of that? And that's within a lot of the realm of care coordination, is we have to understand those pieces, and how to navigate insurance, how to navigate nonprofits, FSA, HSA, just all of the works. So it was a natural transition over to, solely focusing on the benefit navigation piece.
Great. And I think one of the first questions is, how would somebody even know about MINE Maternity? How would they know even to find you? So
I love that. That's a great question, because that is something we are trying to expand upon at the moment.
Sure you are.
Oh, great.
Right.
So one thing, at first, when we first started, we were going directly to individuals. And that was a really hard, as I like to say, a really hard sale, because people didn't know us. They didn't trust us. What are you saying? You can help me with sensitive information in my life at a very sensitive time period. Hence that pregnancy, birth, postpartum period. So that's where we started working with providers. So hopefully your provider or even your Medicaid office knows about MINE Maternity because we are partnered with you all. So we're really working on partnerships.
Yeah, that is having worked in marketing in healthcare for as long as I have. And honestly, a lot of the people that come on the show, it's kind of a common thread. Going direct to consumer is really hard. It's super noisy. And also it's that trust factor is so huge in healthcare. People don't just trust anything, right? But to show up through your provider or your health plan, like that is huge. It establishes trust right out the gate. So I feel like I can name off even, I won't, but like I know that there's like a few people that at least come on the show that were doing the same thing and then realized, wait a second, no, we've got to go through the provider, through the health plan, through the employer, right? That's another huge channel, because that's where you can have the biggest impact and you can show up and impact more lives too. So, yeah.
And once the providers heard what we were doing, we were out there, like handing out flyers, handing out cards. This is what we do. This is what we do. The moment providers heard of us, it was instant connection. It was like, we see the value you would provide our business, because we work with a lot of solo practices, but also like collectives and agencies or like small clinics. So they said, we can see the value because we don't have the bandwidth to answer these benefit and insurance questions or help our patients or clients, depending on, how they refer to them, but, help our clients with the care coordination piece. We don't have the bandwidth. So the moment they found MINE Maternity, we found them. And then of course, once they said, hey, my client, meet MINE Maternity. Oh, okay. Hi, nice to meet you. Here's my life story. So
that's amazing. Yeah, I think that's so true though about like showing up through the provider's office and that they need you just as much as, the members or the patients need you and that you need them in order to have the business. So it's a really great ecosystem that you're building. And providers, I feel like, what is that? Every episode we talk about how providers are stressed out beyond and burdened and all the things. So
we have a lot of episodes with people trying to deal with that issue. We just had Guava back on for the third time. They're doing a lot for that.
Yeah. That's
in a different way. But the insurance part's a big one, especially people don't know what their coverages are because they're so complex and no one ever gets really explained to them. They hand you a bunch of paperwork that's written in legalese that it's too hard to understand. No one's really going to get through that and know what's going on. So yeah, I mean, you guys are basically just an advocate to make sure people get the coverages they're supposed to be able to get, which that's huge. Advocacy is another thing we talk about all the time.
Yes.
Yeah. MINE Maternity is checking all the boxes.
Yeah.
Well, I appreciate that because that's where I started. I started as an advocate. I started as a college student who was not a social worker, but we called them social justice leader. That's my root. So it has to be part of MINE Maternity or, I kind of lost a bit of myself. So.
Yeah. No, I love that.
Sounds like she's going to run for office someday.
Yeah, maybe she
Oh, well, that's big.
Just saying.
Okay, it said it here, I'm running for something.
just remember where you got the idea.
That's right.
Okay. Shout out. Hashtag shout out.
There you go.
So tell us though, like what's changed since the last time we talked to you? I know we were I think it was last summer, so maybe about 9 months. Since we last talked. 9 months. That's how long it takes to make a baby, by the way.
Oh, look at that.
We're going to go with that.
So can't wait to tell you about my postpartum period.
Yeah, exactly.
What were we doing in that first episode?
What are you birthing at MINE Maternity? If I can ask. So yeah, what's changed since then? What's kind of the new big stuff that's going on?
So one of the biggest changes since we first talked was the natural progression. We listen to our people, our community. That's our job, honestly. Listen and then be proactive where we can and just respond. So we've been continuously pushed towards providers. Providers are now, like before it was main, families directly. Then it kind of slowly changed to where it was maybe a little 50-50. And now I would say it's 90-10.
Oh, wow.
We still service families through the providers, but our providers are our number one client. And then they decide on how they want us to interact with their clients, or we just, give them the resources to do it themselves. So explain the insurance bit, or, support with the reimbursement part.
Mm-hmm.
So that's one huge change. So now that we have providers as our main, client, and then their community as our sub-client, we are starting to create tools that support providers. So for instance, one of the things that bothers me the most as a provider at one point, and even now within the insurance scope as being a benefit navigation company, is when you call into the line for the provider line, and especially if you're a maternity provider and you're trying to explain to the insurance representative what it is that you need to confirm your client's benefits on, they don't know any maternity language. I can't tell you how many times I've had to spell the word doula, D-O-U-L-A.
Are you really? Isn't that
I'm not
common?
kidding you.
I'm like,
It's not.
or do we just talk about doulas so much that it's normal?
It's common for us in our world, but the big scope of the insurance companies, they don't know these specialty providers. So I'll talk about midwives, and they'll have 5 different questions that are in the completely wrong different direction, and I have to explain what a midwife is, or the different type of midwives. One that's a certified nurse midwife versus a CPM. So one of the things that we're in the works of creating is a way of actually making it easier to pull up benefits that are maternity specific. So it's not just right now, if you look at your evidence of coverage, aka your summary of benefits.
Summary benefits, yep. Or SOB, as I call it, which
that stands for something else.
it does.
It
Yes,
sure
it does.
And it is unfortunately exactly that when it comes to your not very helpful at times. But if you look at that, all they have is maternity. Maybe they'll have a facility fee. Maybe they'll talk about the physician, and that's it.
Mm-hmm.
They don't talk about, seeing a chiropractor. They don't talk about seeing a pelvic floor therapist and where to find that in your summary of benefits, your SOB. Definitely not doula care. Definitely not midwifery care, even if these things are covered, which I'm seeing. So we're working on closing that gap.
Which doulas are a lot of times.
Yeah. And so they're covered services, but they're not in the summary benefits?
They're not listed out. Yes, that's correct.
Huh. I wonder why.
And I look at one every single day.
They don't
so
want
I'm
you to
seeing
know about
hundreds.
They want the doctors to get the money, not the doulas.
Oh, okay. Yeah. I have so many feelings on that.
It's always because
Very, very early in my career, and Pachet, you'll appreciate this, and where I started in Medicaid. And, half of, I think, on average, state by state, half of births are covered through Medicaid, or the moms are covered through Medicaid. So that's huge. And one of my jobs, one of my responsibilities early on, was the creation of summary benefits. Now, this is back in early mid 2000s when we were still printing them and sending them, and provider network booklets, even that were, out of date, the second you hit the ink hit the paper. But yeah, I would format and edit summary benefits. That was a huge part of my job. That's why I call it an SOB, because it was.
Yes.
Yeah, it was wild though.
They could use your help.
But anyway, so Medicaid, obviously, in state by state, you're going to have different plan coverage. I mean, shoot, even by county within states, right? Because for anyone listening, if you didn't know, there's a whole RFP process that happens with state Medicaid programs, where these health plans like Aetna or United or Cigna or whoever, right? Blue Cross, they go through a pretty big RFP process, request for proposals, to basically pitch the state as to why they would be the best provider of benefits for that Medicaid plan. And often it's only for a couple of counties. So county by county, you're going to have a difference of options for Medicaid plans. And so therefore, to some degree, they're going to have some differences in what they cover and what they don't cover also.
This is another reason why the single payer system would
to complicate things further, which is why MINE Maternity needs to exist, because of that fact alone.
It's becoming my catchphrase around here.
It is. Yeah. So anyway, I don't even know where I was going with that, but somebody
But
center me. Bring me back.
no. I think we should go off of it because
Okay, let's do it.
yeah, let's go off of that. Um, and so recognizing that so first of all, doula, midwifery, but maternity benefits are expanding just in general, which is very, very exciting. And I talked about that excitement the first episode. But now we're really seeing it in 2026. So more commercial plans are having, doula coverage. UHC, United Healthcare, is a good example of where they expanded their doula coverage with their employer benefit, plan and options for employers to opt in for. Medicaid is, we're seeing more states that maybe weren't exactly on the train, the bandwagon, or they were piloting it. And now we're seeing it be full blown, as like a standard benefit. But what I want to say with that is one of the services that we have also expanded into. I did it with the care coordination side, but really highlighting getting more providers into the system, whether it is the Medicaid system, whether it is the insurance system, so they can service more members, they can grow their business, but also they can, have members find them. So it really has been opening up. So that whole credentialing and contracting process is something we are deeply into. And thankfully, we've had a lot of great success with our providers getting credentialed and contracted.
Oh, I love that. And to be clear too, we're using the term providers pretty broadly, right? In this case, because your providers. So again, this is going back to like, I live in this world. So like when we say providers, we often can be referring to a PCP, which is your primary care provider. Sometimes a provider can be whoever, like your kind of, if you have like multiple complex health conditions, it's kind of like your number one, right? Like there's always somebody kind of coordinating like your regular provider. But in your case, when you say providers, you don't mean just OBGYNs. You're talking about clinics and you're talking about doulas and other, can you kind of explain that a little bit?
Yeah, so we live in the specialty, into the specialty realm. So, and that's mostly because, those specialty providers that were once excluded or had limitations. So for instance, lactation consultants having to have an OB or, some other provider watch over them or supervise them, which is, I always say, is absolutely insane because they are the most skilled professional for what they do. There's nobody else that receives the training that they do. But anyways, but now they're able to, work independently, like in more states across the board. And so when I talk about providers, I'm talking about the specialty providers, our doulas, lactation consultants, chiropractors, acupuncturists that may provide fertility or labor support. Definitely midwives. So, and then even maternal health therapists. We work with, the mental health space and getting that specialty care recognized as well.
Yeah.
They use acupuncture for fertility treatment?
It exists. It's, you'd have to decide on your own if it meets your qualifications and scientific research and all of that stuff, but it has been a proven method and within, their scope of research. While some Western medicine research would, say disagree, but it exists.
Yeah, Western medicine's not a big fan of acupuncture.
Yeah. Acupuncture is great.
We really got to get an acupuncturist on here. We talked about that before.
Don't worry, I'm on it, Jeremy.
I should have known.
Yeah, we do actually have a local acupuncturist that's coming on the show.
She's always ahead of me.
Yes.
That's why she's the host and I'm the producer.
That's right. I look for all the amazing guests like you, Pachet. So, so that's kind of, I just wanted to make sure that we were clear on what provider means. So, because the word provider can be used in a lot of different ways across healthcare. So, for the purposes of this conversation, we know who we're talking about. So, big change going through providers for you, and that's opening up, I assume, a whole nother world for MINE Maternity.
Yeah, absolutely. Yeah, whole nother world because we have a couple government contracts that we're partnering with other organizations because now it's it's an economic development plan or strategy or component or contribution. So it's more than just maternal health advocacy, which is our bread and butter and our heart and soul.
Mhm.
But for those who don't care about that, and they won't say they don't care, but for those, entities that don't care about it, one of the ways that we're, putting the angle towards it is that it's economic development. You're giving more people opportunities to thrive in a position, to have, job opportunities and all of that. And it's opening up doors. So if they don't care about the first one, they'll definitely care about the second, because that will only help whoever's in charge.
Now you said government contracts, and maybe you're working on this already, and you mentioned kind of, I don't know, showing up through, say, like a Medicaid plan. Are you establishing contracts with Medicaid plans to essentially for them to be like, hey, all the pregnant women out there or women trying to get pregnant who are on our Medicaid plan, we've got this really great service, MINE Maternity, to help you navigate all the things. Do you have that in place, or is that something that you're looking to do?
I have a different angle for the insurance company,
Okay.
so I won't stay on here, but I'll come back for the third one.
Okay.
Because it's still very much in beta stage.
Gotcha.
But I have a different angle for insurance companies. What I am doing though is working with nonprofits who
Hmm.
have established relationships or have gained the trust of the community, but also have fiscal backing from whatever region that is that they're supporting. So from a county level or from a state level to service Medicaid folks. So we're just
Okay.
a third party contractor to support those individuals with that journey.
Okay. So when you say nonprofits, are these like nonprofits then that are already currently serving like Medicaid populations with maternal health in some way or another? Like they're already established in these
Yep.
communities serving those
Yep.
populations?
That's
Gotcha.
exactly it. Yep. Not
Okay.
trying to reinvent the wheel.
Right. Gotcha.
Hmm.
What do you find? Okay, so I want to get in a little of the politics here. So, MINE Maternity is showing him up in ways to help people navigate through all the kind of crazy that's going on. But we've been seeing a lot of Medicaid cuts in the last year. Um, well, I would say probably more recently than even I wouldn't even go back a full year, right? Like a lot of these cuts came into play pretty recently.
Absolutely.
What are
And
you
more to
seeing?
be, yeah, in the future as well.
And in the future, yeah, you're right
Yeah.
about that. Right, very much in the future, right? We've got stuff coming. What are you seeing changing already in the space? How plan members are being impacted negatively? I'm assuming at this point.
Mhm.
I don't know that there is any positives, but if there are, 100% throw it out there. So,
I'd love to. I like to consider myself a positive person, but the reality is that, so for instance, one of the areas that we're on is on Find Help through the UCI Health
mhm.
partnership, but Find Help is where we're at. And so we've noticed a substantial increase in requests for support and help from the community who's being underserved. And so that's because maybe they've already been cut or they're in a transition period, especially those who are borderline for having Medicaid to begin with. They're most likely definitely getting cut now, or people who need to meet the criterias that weren't once in place. Now they have to meet them, for instance, the working requirement. So what we're seeing from members is a lot of confusion and being just left in this limbo. So, for instance, if they are cut, well, they don't feel, maybe they did, I can't say, but they don't feel, the members don't feel like they were given, well, what are my opportunities and options to continue health insurance if I want to? So for instance, they're not told of, other state plans or marketplaces that they can go to and shop around.
Mhm.
And it's very confusing. So they were left in limbo, and this is not even the full cut, by the way. That's still in the future, as we
Right.
mentioned. But those who are already being cut are left in limbo, and it's very unfortunate. And a lot of enrollment requests, and a lot of enrollment guidance support requests. We're
Oh,
getting,
like how to get covered somewhere else in
yeah,
another
how to
way.
get. Mhm.
And one thing I think we should talk about is when we're talking about why people are getting like what's changed? Why is this even happening? Can you speak to that to any level of
Yes.
knowledge?
Yeah, absolutely. Especially since we service nationwide, so we have to stay up to the policies and the news per se
Mhm.
of every state. Okay, so the one of the reasons why it's happening now, and we're starting to see signs of it already, is that the way that it works is that the federal government was giving money to each state to service their underserved population, so those who needed to be on the Medicaid assistance program. Now that the government has identified that there are cuts going to happen and are already happening for some of these states, the states that didn't have a surplus of funds, like California or New York, who can move around some things in their budget to help support that change, they're having to completely just cut it altogether. And so we're seeing a lot of that for the southern states or maybe the Midwestern states, and some of the East Coast states that are smaller, where they literally don't have the budget. And that's just because of their own economics as a state. So that's why people are starting to get cut now, because the financial responsibility has now been identified to be per state. So states that don't receive a lot of money or don't don't have a lot of taxes coming from their patrons, they literally don't have the money to support the Medicaid process.
And those are the states that need it the most
Oh, almost always.
because
Yep.
they have the poorest people who need the coverage the most.
Yes. And unfortunately, through communication and possible miscommunication to them, they voted to not receive those benefits.
So they're hurting
Now.
themselves
Yes.
in the end. Yeah.
Yeah, this is why Pachet needs to run for office, right here.
Oh my gosh.
Okay, Jeremy's is going to keep dropping this one.
I need to know what's my slogan, Jeremy? What's my slogan?
Yeah.
Ooh,
Oh, right on the spot. Can you do this?
ask me again at the end.
All right, he'll come up with something. But in terms of the qualifications, right, for Medicaid, so we have the funding issue. Like, is it the federal poverty level? Is that changing and in to react to the lack of funding so that less people are covered? Do you know? You may not know the answer. This is me kind of spitballing here a little bit, and I don't know it either. So
Absolutely. So there are changes to there absolutely are going to be changes to who can qualify now. Each state does it differently. So for instance, I've worked with some states to where, unfortunately, a pregnant individual doesn't actually qualify for their Medicaid because of the other stipulations that they had. So just being pregnant alone doesn't qualify someone for receiving Medicaid coverage if they don't have insurance coverage. So it depends on how each state does it. So for instance, some states do it based off of age, some do it based off of income. Well, more than just one factor. Sorry, it's not just age, but income is absolutely a factor. But what that bracket now is going to be, absolutely, I can see it changing. But it's again per state. So you really have to look into your own states to see if they've changed their qualifications and how.
What would you tell? And I feel like this is like your sweet spot here at Pache, is that I can't imagine if I was on Medicaid and I am pregnant, or I would assume soon to be pregnant, and all of a sudden I lose my coverage, but I'm also in that gray area, right? Where I don't qualify for, maybe I don't qualify for employee benefits, right? Maybe it's not offered through my employer. Maybe I can't afford healthcare through the exchange, right? The marketplace, the ACA plans, Obamacare, whatever you guys want to call it. I hate that people call it Obamacare. It's the ACA plans. And the ACA plans they do offer some really great protections. You are not a pre-existing condition as a pregnant woman. I experienced that, actually. I was self-employed.
That was the biggest thing about that, was the pre-existing condition.
There are really wonderful things about the ACA, but if you're in that spot, what do you do? I feel like that's where MINE Maternity can really shine, because you can show up and be like, all right, sister, I got you. What happens to these people? I would be terrified if I was not,
Oh, absolutely. I mean, we always hear about how expensive birthing in America is. So the last thing you need, and that's beyond, first you want care. You want to know that you can have care, receive care, that you'll be treated with respect. Unfortunately, there is I've witnessed biases between those who are uninsured completely, those who have maybe Medicaid insurance, and then those who have private insurance, and how they're treated in the healthcare system. And then there's the financial component, which is very huge because that can lead to prenatal depression. It can lead to postpartum depression. So it's not something we can just say doesn't matter, because it absolutely does for our families. So what I recommend for folks is I'll offer 3 suggestions. One is to take a look at the health share options. So there are health share companies out there.
I have heard of this. Expound on this. I'm excited.
Yes. So I'll offer 3 suggestions. One is a health share plan, and working with a health share company. And so what that's like is you have a community of individuals who are contributing in a sense to one another's opportunities. I can't say exactly they're contributing to your specific plan, but in a sense, you're putting into a pool that when you need care, you can be taken care of yourself, and others can utilize what needs they have. But essentially, it drives costs down. That's the biggest part of it. So you're part of a community, and it drives the cost down. Now, here's something that's very unique and very interesting, is that this is not so much a foreign concept. In fact, it should be a concept that's implemented, and it already is, by countries that we hear, hey, they have free health, care. When we hear that from other countries, they're part of that pool. They're part of that community share. And that's what drives the cost of healthcare down, because what makes healthcare, especially in the United States, so expensive is that we have so many little pockets of people paying. So you have like one company paying this plan, and then maybe another company paying a different plan, and that drives the cost up. But the more
we call that risk pool in the insurance world, yeah.
There you go. And the more individuals that you have to service an area or service, a plan, the cheaper the cost is. That's just how it works. And one of the reasons why our health insurance companies that are leading it don't want that to happen, because that would, drastically change their margins. But that's how Medicaid can get away with having costs that are so much lower. You're paying a maybe $0 to $15 copay, when if you get a private pay plan, you're paying $35 to $40 maybe for the same type of visit. So anyways, large explanation, a little bit on.
Once again, is why the single payer healthcare system would be a good idea.
Yeah. And I'd say even Medicare, right? Same kind of concept, right? You're paying into it most of your life through your taxes, and then when you turn 65, you've got the and that's a national risk pool.
Yes. So the larger the pool, the better it is. So look into health share plans to see if maybe your cost as a monthly premium, or even, your deductible, so aka the amount of money you have to put in before you can start receiving benefits, is lower, because I can oftentimes guarantee that you'll find something that's beneficial to you.
Are health share plans by state though, Pachet? Is it like state specific, or I don't know a whole lot about these, so.
No worries. So there are state specific ones, and oftentimes actually they can be state specific. Okay. That's just because they still very much work like insurance companies. And so the needs and policies that have to be met for one state can be different for another state. That's why when you see Anthem, it's not Anthem that you have, it's Anthem and then whatever their sub plan is. And actually there's a sub plan to that that you really have. So Anthem California versus Anthem another state. Very different companies, though they have the same overarching company. So most likely you're going to find a state specific one.
Gotcha. Okay, cool.
Yeah. So that's the first idea that I would suggest for people to find. The second, and I love to highlight, are nonprofits, especially for our maternity community, but our nonprofits are fabulous. So our nonprofits are filling in the space where traditional clinics and hospitals and providers aren't. So for instance, they're hosting group sessions, group medical sessions. So it's like midwives coming together and maybe having a group session and then branching off to work with people one-on-one. greatly reduces the cost and or is completely free because that nonprofit got a grant to support this initiative. And a lot of states are needing to fund nonprofits to fill in this gap, because if Medicaid's not going to do it, and if traditional healthcare and insurance companies aren't going to fill in the gap, individuals, and that's where our nonprofits come into place. Even though they're not an individual, it's like still the smaller, that real community aspect, they're filling in the gap. So they have more funding opportunities.
Yay for nonprofits and the people who are here to put those in place, because you can't have a bunch of uninsured, uncovered, pregnant women walking around, because guess where they're going to end up when they don't have a doctor? In the ER. What happens when you end up in the ER? It's very expensive.
Yeah.
Who pays for that?
Way more than that.
We all do.
Taxpayers do.
It is a domino effect. Just FYI, everybody.
I mean, I see all the time how we pay more per person out of the tax fund for healthcare than the countries that actually have socialized healthcare.
Yes.
Right?
We pay like 5 times more per person out of the tax fund for healthcare than if we had a single payer taxpayers or a single payer healthcare system.
It's so backwards.
It doesn't make any sense.
Yeah.
It really doesn't.
Yeah, it doesn't.
Unless you're a billionaire, and then it makes sense.
Well, when you're a billionaire, it doesn't matter.
Well, because that's who it benefits to do it that way.
Exactly. But most people are not.
And
so
speaking of politics, I have your slogan. You ready?
Oh, yes.
Pachet knows the way.
Hey, I like it.
Let me know if you need a speechwriter when you start running.
Okay. Will do.
And then we're going to have her come on.
Pachet knows the way.
We're going to have to
not vote for that.
You're going to have to come on our new series called Your Vote, Your Health, which we just launched, by the way. So
there you go.
Oh, yeah. Yeah.
Politicians.
Yeah. We got people coming on talking about the impacts of policy and legislation on healthcare. So
yes. Oh, wow.
Yeah.
Definitely.
Anyway, you've got a number 3 here.
Oh, yeah. Sorry.
Before we completely derail this conversation.
I like to tangent.
Yeah. What's your number 3 piece of advice, Pachet?
Okay, so we have our health shares, we have our nonprofits. The other, which might surprise folks, is paying out of pocket. And
cash pay.
Oh,
cash pay.
that one sounds scary.
So let me explain why, when people think that they might think I'm crazy, but I almost promise you I'm not. Cash pay. When you opt in for a cash pay option, especially with maternity care, okay? The way maternity care is built, for the most part, is that it is actually a package. It's a package price. It's a package deal. So there's so many prenatals, there's the birth and labor cost, and then there's the postpartum cost. And it's a package, in a sense, in the background of the insurance world. And so what that means is that if you were to call in and say, I'm paying out of cash, I'm cash paying, what is the price for my maternity care? They actually will provide that to you. And it is substantially less than if you were to use your insurance. And the reason why is because there's a whole other system to one up one another and to gain as much as possible when it comes to the balance between hospitals, insurance companies, and the government, whatever that may be. So, your state or local agency or even federal agency. They all are working together to get as much as they can possible. That's why when you pay out of pocket for something, it may be $50, but when you see your insurance plan and you used your insurance, it was suddenly $300. And then,
it's
the
wildly different.
Covered $250 of it. And then you're still maybe paying $50, but the price you see is that $300. It was never $300.
Yeah.
Okay. It was $50 to begin with. They just found a way to mark it up, again, for all 3 to somehow benefit or for one to get more than the other.
I did cash pay.
I see that at the dentist's office quite a number of times.
Because not a lot of people have dental coverage. And it's
I pay cash at the dentist, and they make a point of showing you the paperwork. So if you're paying cash, this is what you're going to pay. If you had insurance, this is what we'd be charging. And it'll be a few $100 that you're paying cash, and the insurance is like $2,000.
Yeah.
Like it's like so many times more. It's crazy.
I was cash pay with Zane. So that's pre-ACA. I couldn't get covered unless I got like a maternity rider. But I was otherwise considered a pre-existing condition, and we were both self-employed, my husband and I. So we did cash pay, and I just went on a payment plan with my OB over
Mhm.
the course of the pregnancy. I think
Yes.
it was, and this was back in 2008.
Yep.
It was like I want to say it was like $1,800 or something like that, right? And so it was broken into payments. And then when I went to the hospital, because I was
Yes.
cash pay,
Yep.
it depended on which hospital I went to, the cash pay was different. So
Mhm.
fancier, better hospital, more money. If they have a, pediatric NICU, more
Of course.
money because of access and all that kind of stuff. So there's a lot of factors too. So if you are going to do cash pay for a hospital, you're not in network, right? You can choose wherever you go, wherever the heck you want.
Wherever you want to go.
Find the place that you feel the most comfortable with, that's affordable, and you can also get on a payment plan with them as well. So, um, I want to ask though, and I know I want to be considerate of your time because we have to let you go here in a few,
You got a hard
but
cut here.
direct primary care is something that is growing. Are you seeing that in the OB space as well? Like, direct primary care, by the way, it's like where you pay like a membership fee and you basically go in and see your PCP whenever you want, like $50 a month per person. That is a growing trend, but I haven't heard about it for OBs. Have you?
I haven't as well.
Okay.
I haven't heard that much about it now, but the fact that we're seeing some of the community birth workers applying this concept, not so much a monthly subscription, but that group concept or finding ways to create a
Mhm.
different pricing model, I have no doubt that it is going to blend over into the traditional OB world,
Yeah.
especially for OBs that have private practices. So
Hmm.
not every
Yes.
OB is part of a huge,
Like
hospital and has
health
to
system.
health system. There are so many, individual clinic, one person, two people. I love that freeze frame. But one person,
Oh,
two people clinics out for them to work with. So
yeah.
I can see.
It's just, I mean, it's a little different dynamic than a PCP doing the kind of monthly subscription thing because it's only 9 months
Right.
or however long after, maybe, but maybe a
Sure.
year that you're a member. So you'd have to like have a certain number of clients, and then when you lose one, you take one in, you lose one, you take one
Yeah.
in, I guess would be the
Or
process there,
you
right? Something like that.
or partner with other providers that fill in that experience. So for instance, if you have a group per se that covers the fertility, right? You have a fertility partner. So you have
Mhm.
all those fertility individuals and then they blend into the maternity world. And then you have them for at least 1 to 2 years because of the pregnancy component, then the postpartum component. And then you transition over to the pediatric side of it. You have
Oh,
that type of
Okay.
village. That's a minimum of 1 to 5 years. And what, on average, what's the
Sure.
pediatric age that
I'm
they keep their
pediatric,
kid in?
17 years old.
I mean, I'm
There
still
you go.
taking my 12-year-old to the pediatricians, whereas I've transferred my older son, who's about to turn 17. I moved into like a regular primary care practice for
There you
adults
go.
this past year, but that's a
Mhm.
long time, and especially if you have
Yeah.
multiple kids.
That's a good point. You build your own
And
little
when you trust someone, you're going to stay with them for
Hmm.
as long as you can. As,
Yeah. Yeah, the
so,
cash pay thing is interesting, or the direct primary care, there's a surgery center in Colorado. I actually was trying to get them to come on. They're doing it. I think it's because provider practices, particularly independent ones, the insurance is just making it so damn hard for them to even operate and function that they have to hire people to deal with insurance that it's just easier just to do cash pay.
and that's the thing about cash pay too, for those who are like, I don't know if that's the best option for me. Well, consider this is that hospitals, clinics, providers, they will work with you if you are
Yes, they
cash
will.
pay. As someone who does billing for insurance, as a company that does credentialing and all that insurance navigation portion for the providers, I can tell you that it can be very difficult and time consuming, and you have to work with rejections and just a whole lot of unknown when working with insurance and billing insurance. But if you have someone who's willing to say, hey, I can pay you outright, but I need a monthly plan, like you suggested, I need a monthly plan, or even you can negotiate. People
Hmm.
don't think about that enough, how much you can negotiate your hospital bills.
Yep.
Um, Absolutely things to consider.
Yeah. Great. Well, I love that we're ending on offering solutions. I like having answers and solutions.
Yeah.
It's good stuff. Pachet, I'm so glad that you came on. I want to make sure that people know how to find you before we let you go. What is the best way for folks to get a hold of you, either from a provider who might want to partner with you and bring you in as a kind of, service or whatever partnership to their patients, or people that want to just come directly to you? Where are you?
Absolutely. So the website's a great place to start. So it's www.mine, it's MINE, minematernity.com. It's under construction right now because one of the things that we have upcoming, part of the exciting news, is that we are establishing a MINE credit program. So it is a subscription model for monthly subscriptions, or you can do one-off payments, but you can utilize your credits for benefit navigation services that you need.
Oh,
So,
wow.
and when you need it. So for those who have a real flow and high need, monthly subscription, absolutely. But for those who are maybe a solo practice or just starting, absolutely, they can have an in-house benefit navigator without having to hire a whole billing company that may or not know their space. So
Gotcha.
That's very
that's
cool.
that. So the website's under construction now, but hopefully by the time this launches, it will be up and live for people to explore. There's always info at minematernity.com. And then there's Instagram, MINE Maternity, and LinkedIn.
Great. And LinkedIn.
Yeah.
Yeah, this won't be out for a few weeks anyway. So
Yeah. We'll get all this in the show notes so everyone can find you, and make sure to plug all that good, exciting provider stuff that you're doing. So congrats on all of that and the growth, and just I'm sure that is just opening up lots of doors. So
I'm excited. Very, very
Yeah.
excited.
Awesome. Thanks again for coming on. So happy to have you back, and wishing you all the luck here. And I know you got to run. So,
Yeah.
So Pachet knows the way.
oh,
Pachet knows the way. There we go. All right, everybody. Take
he's
care.
got you. All right. We'll talk to you soon.
Sounds good. Bye.
Okay.
Thanks for joining us on the Healthcare Uprising. Make sure to hit those like and subscribe buttons before you go, and take a moment to think of a friend and hit that share button. You can find us on all the major audio platforms, and we've got video on YouTube if you want to watch us in action.
You can also find us on social media on LinkedIn, TikTok, and Instagram. Just search Healthcare Uprising to find us. And if you're a new company with a cool new product, if you're someone innovating alternative methods for the health and wellness space, or if you have a personal healthcare journey you'd like to share with us here at The Uprising, please email us at healthcareuprising@gmail.com, and we'll get back to you about coming on the show. Well, that's all for this dose of Healthcare Uprising. Until the next time, keep looking for the good in the world, because sometimes it's where you least expect it.
We are not doctors and we don't play one on TV. If you need medical advice, consult with your physician or a healthcare professional. This has been a Shut Up production.
Shut up!